Hello, Assalamualaikum. Anis dengar ke?
Dengar.
Okay.
Assalamualaikum, Prof.
Alaikum salam wa rahmatullah. How are you?
Fine, Alhamdulillah, Prof.
Alhamdulillah, all was fine. Salam for everyone. Inshallah, we are going to go to a session about long cases. We are going to start the first case, hoping to finish around 8, and then get a break for 10 to 15 minutes for Maghrib, and we can continue after that, inshallah. Is it okay?
Okay, Prof.
Okay. So let us start by al-Kitab.
Rahmanirrahim.
Who will be the presenter today?
My name is Aqila. I will be the doctor for today's session for the first case.
Okay. Who else with you?
Me, Prof. I will be the patient for the first case. Patient's mother.
Inshallah, good patience. Okay, who will be the one who is preparing Oski?
Mm, But I only prepare about 4 questions.
Okay, that's fine. Okay, someone please adjust the timing for history for 20 minutes, please. Everyone,
Okay,
please.
Prof. I will adjust for the timing.
Yes, please. And everyone try to turn off his voice, please. Okay, go ahead, please.
Assalamualaikum. I am Dr. Aqila, so I am the houseman in charge of this pediatrics ward. May I know with whom am I talking to right now?
My name is Wardati. And I'm here accompanying my son.
That's
There's,
nice. What's the name of your son?
Shazrin.
Shazrin. Okay. So can I ask a few questions about your son's condition? First, I'll start by asking how old is your son right now?
Shazrin is 10 years old.
10 years old. I see. So what concerns you that you brought him to the hospital today?
Actually, he was having fever for already 4 days, and also he had watery diarrhea for 2 days, and today is very specific. So on the day of admission is very concerning for me because he had he defecated in his trousers, so I think this is very bad. So that's why I bring him to the hospital.
So he was just admitted today?
No, today is already day 2 of admission.
Day 2 of
So
admission.
after 4 days of fever, he was I bring him to the hospital. He was admitted.
I see. Before that, may I know if your son has any underlying condition or underlying disease previously?
Had heart disease, but it's
Heart
not
disease.
really serious lah.
Okay. First, may I know further details about the fever? As you mentioned earlier, the fever has been occurring for 4 days, right? How did you first notice that he had the fever?
Actually, during the first day of fever, I feel him very warm, so I record his temperature. It was about 38.9. So, but then so that's why I bring him to the X-ray. So the temperature is 38.9, and then I try to reduce the temperature by putting on clothes over the forehead, but then still the temperature does not going down. So, and then on the second day, the fever still persists, so I bring him to the emergency department. But then no investigation was done, and he was only given paracetamol, Panadol.
Mm-hmm.
Then we went home again.
So you did give him the paracetamol. Does the fever reduce with the use of paracetamol?
Still the fever still there, but then after we went back from the hospital, the fever on and off, until day
Mm-hmm.
4 fever. So yeah,
So by meaning of on and off fever, it means that it is elevated temporarily by the use of paracetamol. Is it like that?
yeah, I think so. But then after that, the fever came back.
Oh, after that, the fever came back. Okay. Is there any like specific pattern to the fever? For example, is it occurs like in is it continuous? You said earlier it's intermittent, right? But is the fever pattern or fever temperature gets higher throughout the day, and then of the coming morning it resets to normal and then starts to elevate as the day goes? Or is there any no specific pattern?
During the morning, the fever is okay, but then as it first the night, then the fever will be higher.
I see. Does he complain of having any chills or rigors? Like he feels it was cold during the fever, or if there is he felt like shaking during the fever.
I don't see him tasting, and he also does not complain during any pills.
Okay, okay. Apart from the fever, does he have any other symptom? You mentioned earlier he had watery diarrhea, right? Mm-hmm.
Yeah.
Can you explain more about the watery diarrhea?
So about the diarrhea, it already happened 2 days before he was admitted,
Mm-hmm.
and it occurs about like 5 times per day.
5 times
And
per day. I
uh,
see.
what concerns me most is during the day of admission because he don't he don't have the time to go to the toilet with difficulty in his trousers. So I think this is very bad. That's why I bring to the hospital.
I see.
At that time he looked very lethargic, very weak.
Very
So
big.
concerns me most.
You notice he appeared very weak with the onset of fever or with the onset of diarrhea, which is like 5 times per day.
Since the onset of diarrhea.
Just instance of diarrhea. May I ask about the stool itself? What about the volume of the stool? Does it increase compared to normal?
I'm not sure because I was not there with him, but then I can see that he often goes to the toilet because he had diarrhea. But
I
I'm not sure
see.
how much.
Does he mentions about the content of the stool? Whether is there any blood in it?
I did ask him, but then he said there is no blood or
No
anything,
blood.
just the color kind of like yellowish green like that.
Yellowish green. Does the stool have like any malodorous smell, or is it just similar like the normal stool?
For me, I think it's not quite bad lah, fortunately.
Okay.
But then I'm not sure if it's normal or not.
Okay. Is there any mucus together with the stool?
Hmm.
No. But it's watery inconsistency, right? You mentioned earlier.
Yeah.
Okay. Apart from that, does he has any other symptoms apart from the fever and also watery diarrhea?
He also I can also see that he is vomiting since
Mm-hmm.
the first day of fever, but then only twice lah. During the 4 days
Only.
of fever, he only vomit twice.
Uh, Pardon me. The vomiting has occurred since the first day of fever.
Yes, but then
Okay.
for throughout the 4 days, he only vomit for 2 times only.
Oh, okay. Not 2 times per day. Only two
Mm.
episodes. What about the content of the vomitus?
Mm. He
Is it
basically vomit out whatever he eats prior to that lah.
mm,
Doesn't get digested.
undigested food? Basically, okay. Does it has like any greenish consistency? What we call like bilious or greenish color vomitus?
And the color of the food and kind of like watery.
For the 2 episodes, what about the volume of the vomiters in each episode?
About 1 cup each time.
1 cup per time. See. Is there any blood in the vomiters?
No,
No blood in the vomiters.
just water.
Is it like associated with feeling of nauseated before he
Yeah,
vomits?
he did nauseated before he vomit.
So the 2 episodes of vomiting actually occurs on the first day of fever and also day what of fever?
Then the 4th day.
The 4th day, which is yesterday, is it? Or today?
Today fire.
Today is the 4th day
Today,
of fever.
today is second day of admission.
Uh-huh.
Today is second day of admission, so he vomit first day of fever and after the 4th day of fever.
I see. Okay. Apart from that, did you notice he has any other symptoms?
Also complain of having headache, but I'm not
Headache.
sure since when, but then he had headache over this area.
Or only the... Oh, it's generalized lah, the headache. Oh.
Like over here.
Mm.
It was continuous.
Continuous. Did he mentions whether, if I would say 1 is the least severe pain and 10 is the most severe pain, what score will he give to the pain of headache?
Actually, I didn't ask him, but then he said the headache is similar, similar intensity lah, but I'm not sure how severe.
Okay. Does like the headache disturbs his sleep or disturbs his daily activity?
Yeah, I think not really. I think not because of the headache only, but because of his maybe actually very weak and also
Very weak.
had reduced in appetite and also reduced in oral intake. So I think that's why.
So he had reduced oral intake since the onset of fever, right? Okay. Did he mention specifically about the characteristic of the headache which he having?
No, he just said that he had fever over here.
Okay. He does not mention whether it radiates or goes elsewhere over the head.
So far that I know, no.
Okay. Does he also complain of having like some muscle ache or joint ache?
No.
No. If he has any like upper respiratory infection symptoms such as cough, does he have any cough?
No cough.
No cough. No runny nose. Does he
I
has?
noticed his face is quite red now.
Face is quite red. Since the onset of fever? Did you notice his eyes become red?
No.
No.
The eyes is clear.
You notice that he has any rash over his body?
So that I see, I don't see any rash. But then however, I'm not sure lah. Maybe they are too small. I'm not sure.
Okay, not that you notice of lah. Okay. Does he complains of having any like pain behind the eye or what we call retroorbital pain? No. Does he has any like yellowish discoloration of the eye or of the skin?
I think no.
Together with the fever or together with the onset of diarrhea, does he complains of having any abdominal pain?
Before I mentioned there was no abdominal pain, but then today he complained of abdominal pain at the center.
At the central, is it continuous? What about the pattern of the pain?
Then when I spoke to the doctor, then doctor gave him medication, then the pain will resolve.
Oh, I see. So it's only occurs for a short duration?
Yeah.
Like how many minutes? Is it intermittent, like multiple episode of the abdominal pain, or only once of the abdominal pain?
One.
Only once. Does he mention specifically like how severe is the pain towards him? Does it disturbs his sleep or anything? No. Does he mention specifically if the central abdominal pain radiates or go elsewhere around the abdomen?
He didn't say that. He just said that the cancer.
Okay, I see. So it has been going for only one day and one episode only, right? Okay. Mm, mm. You mentioned earlier about him having poor oral intake, like reduced oral intake. So how much does he drinks or eats since the onset of fever, as compared to the usual habit?
Usually he eats like meals a day, three full meals a day, but then currently he only tolerate water.
Currently only tolerate water. Does he mention specifically why is he not having good oral intake? Is it because of the fever or because of the pain?
He said that he doesn't have any appetite to eat.
Doesn't have any appetite. I see. How about his urinary output? Can he urinate normally, or does he has reduced in frequency of urination?
I don't really ask him, but then he said he is like normal.
Like normal. Okay. Does he has like any episode of gum bleeding,
Kalau no, no.
bleeding from the nose? Does he have any bleeding from the nose? He does not have any cough, right? So is there any episode of blooding, coughing out blood? No. Is there any blood? There's no blood in the stool, right? You mentioned earlier.
Yes. No back in the stool, no back in the urine.
I see. Okay. Does he have ever mentioned about having difficulty breathing or shortness of breath?
No shortness of breath, no coughing.
No coffee. Is there any episode of chest pain? No. Is there any like abdominal distension? No. See. Like apart from him, does any of your family members actually have similar symptoms?
Yeah, this elder brother.
His elder brother. Has his elder brother been going to the hospital or has been diagnosed with anything?
So the brother had similar symptoms with him, headache, fever, but then he does not want it lah. Just that the doctor said he needs to drink a lot of water.
I see. Has him been eating outside at unfamiliar place previously before the onset of diarrhea or fever?
Yeah, one day before he had that fever, he did go out with his friend and eat outside. And then I asked him whether his friend had the same symptom with him. He said no. But then on the same day, we also do some gotong royong. We clean up the house compartment lah.
Okay. Your house compartment, you mean, right? Yeah. It's like at your neighborhood there is case of dengue. Are you living in a dengue prone area?
Actually, yes.
Yes.
Recently there is fogging then.
How recent is recently?
The last
Last week, only last week. I see. Does he before the onset of fever and diarrhea? Does he go to jungle trekking? Is there any history of jungle trekking? No. How about swimming or water contact activity? No. I'm sorry to ask this, but is there, like, have you seen rat infestation in your house particularly?
Once in a while.
Only once in a while. Has he ever complained of having like cough pain? No. There's not even muscle ache, right? You mentioned earlier. No muscle ache or joint pain.
Apart from the symptoms that I mentioned, I think we don't have any other symptoms.
Okay. You mentioned that he appeared lethargic, right? Why did you say so? Is it because he has reduced inactivity or anything?
Because he only sleeping and just lying on the couch
Okay.
almost throughout the day.
Have you noticed like he had some episodes of confusion?
No,
No, like impact consciousness. He was fine throughout. He was alert and conscious throughout.
just sleeping. I see him sleeping quite loud.
Pardon me?
I see
Sorry.
him sleeping all day.
Okay. um. So now I'd like to ask about your child's past medical history. So you mentioned earlier that he had underlying heart disease, right? May I know further details about the underlying heart disease?
About that, first he was diagnosed when he was 1 year old.
Mm-hmm.
And the doctor said that he had some kind of like a hole at
Mm-hmm.
the heart wall.
Mm-hmm.
But then we never did anything because the doctor said that the hole will close on its own. But then as the time goes by, but the hole still not close up. But he doesn't have any symptoms.
He doesn't have shortness of breath, right? You mentioned earlier, no chest pain. Is there any like reduced or limited activity? No.
So
Does
that
he?
we go to the IGN like every year for follow-up.
I see. Okay. So there's no surgery have been done with regard to the heart disease. Okay. Is he on any medication currently?
No, no medication.
No medication currently. Okay. How about his vaccination? Is it up to date? Does he go regularly for immunization so far for the previous years? Yeah. Okay. Now I'd like to ask about the birth history. Have you had any problems while you were carrying him throughout pregnancy?
Me during pregnancy, I had diabetes. I had diabetes when I was pregnant with him, and I was on insulin.
Was he born term or preterm? Like at how many weeks was he born?
40 weeks.
40 weeks. Okay. With birth weight of
2.7.
2.7.
We were delivered with cesarean because the position is not fixed when I was about to deliver, so he keeps on spinning the tummy. So that's why
Okay.
for the
Remaining 1 minute. Remaining 1 minute only.
But apart from that, he had no other significant illness after born.
He only had jaundice, but only for 2 days.
How about his development? Is it like up to age or at par with the other siblings?
Normal.
Yes, normal. Okay. Does any of your family members had any illnesses?
No, I had diabetes, but then on medication.
but already on medication. Okay. Apart from that, there is no other disease in the family. No, I see. Okay. May I know where did you stay?
Kampung Tanjung Selamat.
Kampung Tanjung Selamat. Oh. So it's at Kampung Tanjung Selamat lah, which have the dengue area of Ogimi. Okay. So you live with your all your you have I'm sorry. Shazrin have how many siblings? Three siblings. So you guys are staying in one household. Right?
Yeah.
Yeah. Okay. What are you working as? Or your husband probably?
Husband work as a ambulance driver at the hospital, and I work as a clerk.
Okay. May I know about your household income monthly?
About 4,000 per month.
About 4,000 per month. I see.
Okay, thank you. Can you do now summary, please, Aqila?
Yeah, okay. So I've been given the chance to clerk my patient, Shazrin, a 10-year-old boy with underlying heart disease who presented to the emergency department of hospital with complaint of fever for 4 days duration associated with watery diarrhea for 2 days. So he was apparently well until 4 days prior to admission, where he started to develop fever, in which the mother noticed when he is warm to touch. The recorded temperature at that time were 38.9 degrees Celsius, and the fever is continuous throughout the 4 days, only slightly elevated by tepid sponging and also the use of paracetamol. On day 2 of fever, the mother had already sought medical attention at the emergency department. However, an investigation was done. He was only given paracetamol to be taken at home. The fever was not associated with chills and dry coughs. And apart from the fever, patient also had diarrhea for 2 days duration, starting at the day 3 of fever, which occurs with episodes of about 5 times per day, in which mother described that patient passed watery stool. However, she was unsure of the volume of the stool with content of yellowish colored stool without any blood or mucus, and it was foul smelling. And what concerns the mother was that on the day of admission, due to the increase in bowel motion and also patient actually have passed bowel pus in the trouser, and that's what concerned the mother and brought her to the hospital. Apart from the fever and also watery diarrhea, it is also associated with episodes of vomiting, 2 episodes of vomiting throughout the 4 days, with content of undigested food, no bilious or blood in the vomiters, with volume of 1 cup for each vomiting episode. And the vomiting episode is preceded by episodes of nausea. Apart from that, patient also complained of headache, which is generalized in nature, continuous. However, the mother was unsure about the severity of the headache and also if it was radiated elsewhere. Apart from that, since the onset of fever, patient also had reduced oral intake, in which previously patient would have 3 full meals per day, but currently patient will only tolerate drink or only tolerate water. However, patient still maintain normal urinary habit as per his usual urinary habit. Apart from that, it was not associated with myalgia or arthralgia. There was no upper respiratory tract infection symptoms such as cough, runny nose, or redness of the eyes. No rash was noted by the mother, no retroorbital pain, and no yellowish discoloration of the eyes or the skin, and also no cough pain reported. There is also no bleeding tendency. He had no shortness of breath or chest pain. Upon admission, patient complained of having 1 episode of abdominal pain, which is central in location, for only a brief duration and relief by prescription of medication by the doctor. However, there's no abdominal distension. On further questioning, revealed that his elder brother also have had similar presentation of fever and also diarrhea. And upon further questioning also, it reveals that 1 day prior to the onset of fever, patient had a history of eating outside together with the friends. However, there are no other friends with similar presentation. And patient is living in a dengue-prone area with recent fogging occurring about last week. Patient denies any other history of traveling, jungle trekking, swimming or water contact activity, and there is rat infestation at the house. Patient also has underlying heart disease. Patient also had underlying heart disease, which is diagnosed since the age of 1 year old. However, I was not sure what type of heart disease it was. It could probably be ASD or VSD or AVSD due to the presence of hole in heart wall, which is described by the mother. But otherwise, patient had no failure symptoms such as shortness of breath or chest pain, and no reduce of effort tolerance due to the underlying heart disease. No surgery has been done so far regarding the heart disease, and no medication was received so far regarding the heart disease. And also, patient was not on any other medication. For the immunization history, it was up to date, exclaimed by the mother. And for birth history, antenatally, mother had diabetes mellitus on insulin, and patient was born by a cesarean section at 40 weeks of gestation with birth weight of 2.7 kilogram. Otherwise, there is no significant illness during the neonatal period. For the developmental history, mother claims that it was up to age and at par with other siblings. As for family history, mother had underlying diabetes mellitus on medication. Otherwise, there is no other significant disease running in the family. Mother stays together in one household at Kampung Kanjong, which is a dengue-prone area.
So, what is your working diagnosis now, Aqila?
First, my provisional diagnosis is dengue fever on day 4 of illness with warning sign, which is persistent diarrhea more than 3 times per day. And my differential would be acute gastroenteritis due to the presence of fever, vomiting, and also watery diarrhea. My next differential diagnosis could also be leptospirosis, similar due to the presentation of fever, watery diarrhea, and also vomiting, as well as presence of rat infestation at the home. However, there is no episodes of yellowish discoloration of the skin or the sclera, and also there is no prominent cough pain noted by the patient.
Other differential diagnosis?
Other differential diagnosis could also be typhoid fever. However, it is less likely because there is no specific pattern to the fever itself, in which typhoid fever may come with stepwise pattern of fever.
Any other differential diagnosis?
The differential diagnosis, it could also be malaria, probably due to the presence of fever and also watery diarrhea and also vomiting. However, it's just less likely because there's no yellowish discoloration or history of jungle trekking.
Okay. Do you have any other differential diagnosis?
Due to the presence of fever and also vomiting, I would also consider differential diagnosis of something like meningitis. However, it is less likely because patient had no seizure episodes or impact consciousness episode. However, I forget to ask about the presence of photophobia in this patient.
Yeah, this is a very important one. So your main diagnosis is dengue fever now with meningitis or meningoencephalitis can be with warning sign?
Oh, meningitis. Pardon me, doctor?
Yes. Did you suspect that your diagnosis can be dengue with meningitis and warning signs?
Probably less likely because the dengue itself can manifest as vomiting, and therefore the vomiting may not be manifestation of meningitis in this patient.
He got any convulsion?
No history of seizure during the episode of fever.
No convulsion?
No.
No fitting at all?
No.
Okay, so what is the warning sign, do you know?
the warning sign. One, there is evidence, there could be evidence of clinical fluid accumulation, which can be manifested as pleural effusion or even ascites. With pleural effusion, patient may have shortness of breath or even pleuritic chest pain. With ascites, it may be manifested as abdominal distension. Apart from that, is restlessness and also lethargy. Apart from that, the third one is abdominal pain. And apart from that, the fourth one is mucosal bleed. The fifth one is persistent vomiting or diarrhea at least 3 times per day, and also occurrence of liver enlargement more than 2 cm below the costal margin, or even liver tenderness. And the last warning sign is a laboratory manifestation of increased hematocrit together concurrently with the reduced platelet.
Okay, what investigation you are going to consider?
Okay. So first I will divide my investigation according to bedside and also blood and also imaging test. For bedside investigation, first I may also do a tourniquet test to identify the presence of petechiae or fragility of the capillary, which is positive if there is more than 10 petechiae seen at the area of 1 square inch. And my next bedside investigation could also be rapid combo test for dengue. It would manifest positivity in the NS1 antigen, IgM or IgG. Since today is the day 4 of fever and patient is the febrile, I would expect NS1 antigen to be positive at this point of time. NS1 antigen could be positive from like day 1 to day 5 of illness. However, the persistence of NS1 antigen more than 5 days would indicate that it is a severe dengue. And for IgM, it depends whether primary dengue infection or secondary dengue infection. In primary dengue infection, IgM would be negative starting from day 5 of illness. However, in secondary dengue infection, IgM may be positive from day 7 of illness. And also for IgG, may be positive in both primary and secondary dengue infections starting from day 7 onward. And that's for bedside test. For the blood test, first I would like to do full blood count to look at the few parameters. If I am suspecting dengue, the full blood count should be done serially to see the pattern of hematocrit. Hematocrit would be elevated. And since the patient age is about is 10 years old, so the normal hematocrit in patient with inpatient of 7 to 10 years of 7 to 12 years old is actually less than 40, from 35 to 40, from 31 to 40. So above 40 is considered elevated hematocrit. Apart from that, patient may also have leukopenia, reduced white blood cell, particularly lymphocytes, and also reduction in platelet. Apart from FBC, I would like to also do renal profile because patient has multiple episodes of diarrhea, which can cause patient to be dehydrated and is also a risk of acute kidney injury. So I would like to do renal profile to look at the urea and also creatinine. Apart from that, I'd like also to do serum electrolytes to see if there's any electrolyte disturbance secondary to the vomiting and also diarrhea. And for the third one, I would like to do liver function test to see if there's any evidence of injury to the liver secondary to dengue infection manifested as elevated AST or ALT. And since patient is clinically stable, no complaint of shortness of breath, so I opt to not do any arterial blood gas or venous blood gas because patient is stable. However, if patient suddenly develop onset of respiratory distress or having shortness of breath, I would like to do arterial blood gas to see evidence of metabolic acidosis secondary to shock, which usually occurs in dengue infection. And for imaging, I would like to do chest X-ray as a baseline investigation before admitting patient to the ward because patient with dengue infection may have clinical fluid accumulation which is manifested by pleural effusion. And in the chest X-ray for pleural effusion, it will be manifested by the homogeneous opacity with meniscus sign and also blunting to the costophrenic angle. Apart from that, I may also consider to do ultrasound of the abdomen to identify any clinical fluid accumulation. If the physical sign is suggestive of patient having ascites, such as patient having shifting dullness or fluid tree.
So what is the treatment of dengue?
So mainly treatment of dengue would consist of supportive treatment. For the management of dengue, upon patient admission or upon patient's presentation, first I would like to assess the airway breathing and also circulation, ensure to secure the airway, ensure that patient has adequate breathing and also adequate circulation. I would like to insert 2 large bore granulas and take necessary blood investigation, which has been mentioned earlier. The most important thing to have at this point of time for dengue infection is to have the baseline hematocrit, because later the fluid resuscitation will be tailored according to the level of hematocrit. And after that, I would like to assess hemodynamically the status of the patient, whether the patient is not in shock or in compensated shock or decompensated shock, based on few clinical parameters. And
let us easy. The title now is monitoring, close monitoring, and
close monitoring and fluid resuscitation.
Okay, so it is wise use of fluid, because we are not doing giving fluid routinely, because under fluid and over fluid both are dangerous. So it is very important to make input output and make sure about the hydration status. Good, but you give us an important lesson that in spite you are doing very well, you and your colleague about that case, but during our practice, our mind must be ready. Must be ready, please, most of the time.
I'm sorry, doctor, you muted your...
Yes. The most important during our practice, sometimes we can lose an important clue. Can be COVID.
Yeah, it could be.
Yes, because it is a matter of short time you will be present in the hospital, and you may see patient. If you are not able to put in your mind other differential diagnosis, you may make not a problem for the patient, you may make a problem for the community. So we need to ask again, you must write for us what important point of the history which we need to ask in case of COVID and share it to the group. Okay, this is number one. And how can we diagnose COVID? This is another point. What is the PPE, personal protective equipment, if we suspect any patient with fever and rash and vomiting and diarrhea and headache and all this? What is the PPE levels which you are using? What is level 1? What is level 2? What is level 3? It's very important. This is number one. Number two, the patient has heart disease diagnosed at 1 year of age. So we suspect it can be, usually it is congenital or acquired.
Yes. Congenital.
Why you said heart disease without assigning, usually it is congenital. This is number one. Number two, why not subacute bacterial endocarditis? It has a congenital heart disease. There's fever and other symptoms. So you must be able to comment. COVID must be ruled out by important history again about traveling, about any other family member with that he is in contact, where he is living now. The other point for the clinical, you must comment about subacute bacterial endocarditis, which is very so it is very important. Any doctor is happy to come to a conclusion, but he must ask himself always, do I left something behind my concentration ability at that time or not? Just remember, sometimes one of our colleagues, he saw a child with about 2 months, approaching 2 months, with jaundice and umbilical hernia, and he like that, and he forgot to consider hypothyroidism. Really, he is concentrating about delayed jaundice and making some investigation, and he missed the patient. And when he remembered that it can be hypothyroidism, is very with himself. Now, I may not be able to save the brain of this child. What should I tell to myself, to the family, to the God? So please, we need to be very conscious about the situation which we are dealing with, and to try to be wide-minded for everything. Even if the patient has diarrhea, vomiting, it can be a part of parenteral diarrhea. Do you know what is the difference between enteral and parenteral diarrhea? So it can be a part of systemic disease. It is very important. You didn't comment about hydration state. If we accept that it is dengue with gastroenteritis, because secondary complication of that, we must comment about hydration state. What about his urine output? What about his skin looks dry, looks less elastic, less. At least you must specify for that. Okay, so that is our important lesson for today for this one. Ma'am Wardati, do you have any comments?
I think he led it well, and he asked he covered quite all of the differential diagnosis except for the COVID.
But she cannot come to the end. She didn't ask about the family pedigree, about the social situation, about traveling, about. So I think it must be completed. I know it is not your business. You must be here, but we need to consider that. Okay. Who is going to present now, Oski?
I will share the slide, Prof.
Okay, thank you.
Just a second, Prof. Can you see my slide?
Yes. Okay, so I need another colleague to answer, please.
Okay, anyone want to answer this? Describe and name the rash.
I would like to answer. The rash is usually in dengue fever. It is island of white in the Sea of Red, and the rash occur during the recovery phase.
Okay, true. So Isles of White in the Sea of Red is the characteristic dengue rash. Okay.
Sorry if we come back again for
Okay.
any rash presentation to us, we must be able to comment about the type of the rash. Okay, I mean, what is the type? Is it
macular rash, Prof.
Or a black, bigger size like that? And the distribution, I must ask myself, where is the distribution? It is very important. And is there any specific point like this white islets? And then I must comment for any cutaneous lesion about the skin appendages. Is there any effect in the mucous membrane? Specifically the eye, the mouth, the anal orifices, the external genitalia, as all of this can guide us for severe reaction, which is Doben-Jensen syndrome or erythema marginatum. So it is very important to put also a pathway for comment about any cutaneous lesion. Okay, Inshallah, if we start our clinical, it will be a good to apply this together, because the skin is a very important entrance to a lot of diagnosis. If you see someone with a butterfly fly rash, you must suspect it can be
SLE.
it's SLE. If you find salmon patch rash with some arthritis, you are going to consider systemic onset. Yeah, systemic onset juvenile rheumatoid arthritis. Okay, or idiopathic. So it is very important. A lot of rashes can guide you. If you find at this patient like rose spot, you may consider it can be enterica or typhoid fever. If you find strawberry tongue, you are going to consider. If you found like Bastia's sign, so it is very important to please to go through a lot of picture about the skin. It will help you a lot, inshallah. Okay, thank you. Second slide.
So second slide. What is the name of this test? And what is the principle of this test? Anyone?
خمس دقايق وبنصلي. نصلي كلنا بعد 5 دقايق، متفقين الساعة 8. اتفضل 5. Yes.
Sorry?
Yes. To measure capillary
5 دقايق عشان نعرف.
fragility test.
Yes, this is the tourniquet test. So
How to interpret?
tourniquet test is a test. If we refer to CPG, it's one of the criteria for us to diagnose dengue hemorrhagic fever. One of the bleeding manifestation will be a positive tourniquet test. So it is done by inflating a cuff at the upper arm with a level between the systolic and diastolic blood pressures for about 5 minutes. And then for the positive results, some sources, for example, from Medscape, mentioned that 20 or more petechial formations within 1 square inch is the positive one. While others, for example, the CDC mentioned that 10 or more petechial formations within the inflated region, 1 square inch. So that's the positive results of tourniquet test, indicating dengue hemorrhagic fever.
Yeah, but don't forget that this one will not substitute the formal test if your patient must be done like BT, BTT, FDB like that. It is very important, especially in the children. Sometimes they cannot tolerate to do this test for them for longer time. Okay. Next slide, please.
Next slide. Okay. This is one of the possible features of complication of the disease. What does this indicate?
Thank you.
May I answer?
Yes.
Thank you for this one. You cover the gap good. Okay.
Okay, may I answer these questions? Is this severe dehydration due to because the pictures shows sunken fontanelle in the baby?
Yes.
So 5 other signs that we can see the babies, such as reduced skin turgor, dry mouth, reduced tears, reduced urine output, and lethargy.
What else?
Sunken eye.
Sunken eye.
Yeah. What else?
Capillary refill time.
Okay. What
Skin
else?
turgidity, tachycardia, tachypnea.
Skin turgor. What about urine output?
Yeah.
It is one important marker for dehydration. the mother told you he doesn't pass urine for a lot of hours, it is very important. What else? You must ask about the weight. Is it important for dehydration? Yes, of course. We are going to divide how long is the loss to define. Okay, next slide, because المغرب we need to pray المغرب inshallah. Yes.
So what is this test? Anyone? Yes.
This is dengue rapid test.
Okay. So then what is the, how do we interpret?
So we have two parameter. Yeah, for the dengue NS1. So it means positive when there are red sign here at the T. And for the dengue IgM or IgG, either one or both of them, if there is the line signs, it means positive.
Okay.
Okay, but we must know when is the time of NS1 will be positive and which time is the dengue. Okay, next slide, please.
This is the end slide.
Okay, thank you. Now we can go about 10 to 15 minutes to pray al-Maghrib and restart again, inshallah. Assalamu alaikum wa rahmatullah. Assalamu alaikum.
Salam, Prof.
I think your group, inshallah, need to prepare one case about COVID in infant and children, okay? Just published in UK, the youngest neonates who got COVID is 14 days old. And for pediatric also, there is a lot. So we must know that, please. Sorry, before starting the second case, is there any question to your colleague or to me? No questions? Okay.
No.
So at the end, please, always when you finish one patient, I didn't need to sit during the exam because every patient in the future will be your exam. If you finish any patient, you must ask yourself, anything else? Did I forgot anything? I need to consider any other points. It is very important, okay? Your colleague also said good that there is no signs of heart failure, but we have not enough time to ask here what is the symptoms and signs of heart failure. I think you need to include in your study for every system what is the symptom and signs and even investigation for the organ failure. If you are doing with respiratory, you must be able to answer, is this patient in failure or not? So respiratory failure, what is the symptom? What is the signs? What is the investigation which can tell me, like the blood gas can tell me, is it type 1 or type 2? For heart failure like that, if liver failure, if kidney failure. So it is very important to put this point, inshallah, in your area of attention. Okay. Who is our second presenter today?
Prof, may I ask questions regarding dengue, Prof?
Yes.
Actually, for fluid resuscitation, in terms of the weight that we're going to use, do we need to calculate for the adjusted body weight if the patient is obese or underweight, Prof?
Yes, usually in pediatric perspective, usually we are considering the ideal weight.
Thank you, Prof.
Welcome.
Prof, I also have one question regarding the fluid resuscitation. In fluid resuscitation, in case of dengue, we follow the algorithm that is in the PITS protocol, or why not we consider giving the fluid maintenance according to the holiday SEGA formula?
This is an important point. I used it to tell the one who has protocol. It looks like the one who has a father. Okay, maybe his father is not the top person in the world, but as you have a father, you must respect and follow. And if you need to go outside that career, you need just to discuss, because it is not good. Sometimes you feel that there is bit difference between protocols, between different area. It is not only on scientific matter. It is not only about the handling. The one who is putting the protocol usually is wise man who is putting all varieties together, not only scientific. He may consider scientific, he may consider financial, he may consider availability of some service. He may available a lot of things to come to a conclusion for the protocol. So if you have a protocol, please go through it. And if you have any comment or suggestion, you must discuss with your senior. Because I found someone, he feel very confident, he already open American protocol or England or like that, and he need to apply it directly on his situation. I think sometimes you may find yourself not in the best situation. Okay, so must start by our protocol, and if there is any area of discussion, it will be on a wide area, because now we may consider our situation needs some changes, yes, but it will be done by the senior and recommended with also a protocol area in that situation. Am I clear?
So by that you mean that we should follow the protocol instead of the Herdicida for
Yes,
dengue.
unless the place you are going to work in recommend some modification, you can go through that.
Okay, thank you, Prof.
Welcome. Let us give 20 minutes for the second presenter, who will be?
Okay. So, start. Assalamualaikum. I'm Wardati, a houseman in the General Ward of the Estate. So, may I know who I'm speaking with?
Your voice. Okay, make it more clear, please. Okay, thank you.
Oh.
Go ahead.
May I know who I'm speaking with?
Waalaikumsalam. My name is Akilah.
So may I know why are you here? What concerns you now?
So I'm bringing my 1 year 6-month-old boy. His name is Alif, because he had fever. But what concerns me most is that he had a few episodes of, I think it is fitting today.
So the episode only happened today, is it?
Yes, and also the fever has been for 1 day since yesterday. And also yesterday he had the fitting episode. Today is our second day of admission.
So mean the episode only happened for 1 day and then admission are the same day.
Yes.
So can you elaborate more about the episode?
So he was fine initially until like yesterday. He developed fever. The fever occurs yesterday, and today he still had the fever. I noticed that he started to feel warm when I touched him, and it started like in the morning around 8 a.m. also. I did record the temperature at that time. It was about 39.1 degrees Celsius, if I'm not mistaken. And I did some tepid sponging and also give him some syrup paracetamol. However, it was not relief lah.
So is the fever continuous or is it intermittent?
I think it was continuous, but only like intermittently relieved by the medication.
You bring him to the clinic or other medical attention?
When he only had the fever in the morning, actually I haven't bring him to any hospital. However, around Zohor, around 2 p.m. when we are going outside for lunch, actually, suddenly in the car, I think he had an episode of eating at that time. Only after the first episode that I bring him to the GP lah, in the private clinic.
I know why do you say it's fitting? What do you see at clinic?
Initially, I saw him like appears to stare blankly, and also like being unresponsive to calls for about maybe few seconds before he suddenly developed like the eyeball goes upward, and also he had drooling of saliva at that time. And when I try to hug him, like to regain his consciousness back, I noticed that his limbs appears to be somewhat like stiff. I think it's stiffness. And it occurs for about 3 to 4 minutes before he then regain consciousness back and being responsive to call. However, at that time, after he regained consciousness, he actually looked a bit tired and also drowsy, but he did respond to call at that time. And at that point of time, I quickly bring him to the general practitioner in a private clinic at that time. However, in the clinic, like he was only given, medication which is inserted through his bowel, through his rectum, maybe. I think maybe it's paracetamol, probably. And then the GP there, I think he did not do anything other than that. He only advised me to go to the hospital if another episode of fitting occurs, in which it did. Yes.
So how many long after the first episode that the second fitting occurred?
The first episode occurs at about 1:30 p.m. Or 2 or so. And the second episode occurs when we are at home at about 4 p.m. I think. Yeah.
So only 2 episodes before you bring him to the hospital?
Not really actually. At 4 p.m. at that time, I think he still has that fever because I think he is warm to touch also at that time. And then he suddenly like developed the same episode as the first one, whereby he starts blankly and then his limbs started to feel stiff with uprolling of the eyeball and also drooling of the saliva. But then at that point of time, it occurs at about 3 minutes. However, after the stiffness of the limb and also other symptoms start to subside, he did not regain consciousness at that time. He was unresponsive to call. And I think his limbs, when I touch him, his limbs appears to feel cold. Apart from that, I also noticed that he had like bluish discoloration over the mouth during the second episode of eating. And so we decided to bring him to the hospital. And in the car, again, he developed the third episode of eating.
So in total from 4 p.m. to the last episode in the car, how many minutes?
It occurs after about 15 minutes after the second episode. But the difference was that at that time, during the third episode, after he had some generalized stiffness of the limbs, he started also to develop like shaking or like jerky movement at that time.
So to clarify, in total there is 3 episodes, is it?
Yes.
Okay, and the second to the third episode, there is no, he doesn't, he had loss of consciousness.
Yeah, he did not regain consciousness. Yeah. He was unresponsive.
Okay. Actually, when in the car, is he doing anything in the first episode?
Pardon me?
Is he just during the first episode? What is he doing at the moment?
During the first episode, actually because I was in the car, so I just tried to hug him just like that. But nothing happens and it resolves spontaneously, and so I just bring him to the GP.
So basically, he just sitting and then suddenly he had this blind and like that.
He like had the blank stare for a while before he developed the stiffness and also the rolling of eyeball and everything.
Okay, so is there any like abnormal movement of the mouth, like the mouth keep on open and shut?
No, not that I noticed of.
So is this the first time you had seizures?
Yeah, it's actually the first time. That's why like I'm quite scared, and because it's the first time and he had multiple episodes. Yep.
So apart from the taxicology and also the paracetamol, did you do anything other than that?
No, no.
Mm.
So I don't know what to do at the point in time.
Do you have any bowel inconvenience like after the teaching episode, cleansing of teeth?
I didn't notice that.
Actually, is there any, he had any cough or any nose or any sort of cough or any nose?
He actually had cough and also runny nose, yeah. Also developed yesterday like the onset of fever.
During the same day with the fever?
Yeah.
Is it dry cough or is there any mucus?
I think there is no what you call sputum. I think no sputum, but it sounds like his cough is, what do we call that? Like it has sputum, but the sputum does not appear. He tried to cough. Probably chesty cough, right?
Other than that, other than fever, fixing and also coughing, is there any other symptoms?
No, not in particular.
Yeah. Do you see him like any change in behavior? Or
No.
he become easily irritable?
No, not really. He just appeared fatigue and also lethargic after he developed the fever.
Do you notice any like reduced in movement, like he doesn't really want to move his neck, or is there any symptom like that?
I'm not sure about the movement, move the neck. I'm not really sure. I'm not sure about that.
Or do you notice any like does he don't really want to be in a does he don't really want to be in a well lighted room? Does he seems like he doesn't want to look into lights or sort of?
I think he's fine with the lighting. I think he's fine with the lighting.
How about his feeding? Is there any reduce in or anything or?
Yeah, since the onset of the fever, which is yesterday, he had reduced oral intake. Currently, he is 1 year 6 months old and he has been started on adult diet. He usually eat 3 times per day, but currently he still eat because like I asked him to eat, I feed him. But however, it was reduced in the quantity of the food he takes.
Instead of 3 times per day, then so the frequency is similar, but then reduced in the quantity.
Yes.
Does your boy vomit? Is he vomiting?
Yes, he vomits for about 2 times yesterday.
Only for 1 day.
Only for 1 day after he had the fever.
How about the content of the vomiting?
It consists of only like undigested food.
But it seems like is vomit like usual, or do you see any like peculiar like projectile?
I think it's like the usual, only the usual vomitus.
Does he have any diarrhea?
No.
Or do you notice any like redness in the mouth or any ear discharge?
Only that runny nose and cough.
Is there any other siblings or family members that also have the same symptoms?
It's only me his mother, I had some cough.
So you have the cough first, and then
Yes. Yes.
Does he been sent to like the nursery, or has he been in a crowded area previously?
Yes. Before this, maybe like 1 day or 2 days previously, we did go to pasar, to the market.
Okay.
Mm.
Did you notice any changes in the urine, or if there is any rash at the body that you notice?
I did not notice any rash in particular.
Is there any other symptoms that I've not mentioned?
I think no. No, apart from cough and runny nose, I did not notice he had any like rapid breathing. I did not notice. I think he do not have symptoms.
So for the previously, did he have any hospitalization or any medication?
This is actually his third hospitalization. He has been hospitalized for twice when he was 7 months old and also 10 months old, and both is due to like infection inside the mouth. I think the doctor mentioned it's something like tonsillitis.
Okay. Is there any surgery done for the tonsil?
No.
Apart from that, is there any other medical condition that he had previously?
No, he was fine and well otherwise.
So you about the pregnancy, is there any significance when you were pregnant with him? Is there any complication?
No, I am well throughout the pregnancy. He was born normally at 38 weeks. His birth weight was about 2.1 kilogram. Otherwise, he was normal. The point.
Is he to the usual, or is it cesarean, or is it the usual way of living?
The normal labor.
He was not diagnosed with any disease at that time.
No, he was fine.
How about his development? Is there any delay, or is it up to par with other siblings?
He is the second child. And I think it is pretty much similar to his elder sibling, his brother. I think it's quite similar.
How about his vaccination? Is it up to the age?
Yes, I did go follow up at the KK to take immunization according to the schedule time.
What is the latest vaccine that he had?
I didn't quite remember. Can you name a few? I think currently he is 1 year 6 months. What is the latest? He had that DTaP. Yeah. I remember he had BCG, Hep B during birth, and then he also had the DP. Apa tadi?
Any
DTAP.
HIV
Yeah.
vaccine?
No. I don't particularly remember actually about the name of
But
the
then
vaccination.
you follow the schedule as mentioned.
Yep.
So for the history, is there any you notice apart from the scientific, apart from the British direction, do you notice any failure, any fail with the face?
No. I only noticed he had the blue discoloration at time that I think he is fitting.
You realize that he become weak, I mean, the limb just fall on its own, or sudden,
No,
or did he fall to the ground? Is there any symptom like that?
no, because actually when he had the fitting, it was in the car. The second and the third fitting was in the car, and although he didn't regain the consciousness, we just hugged him and brought him to the emergency department. So when we reached the emergency department, he actually has not regained his consciousness yet.
I think there is no reflex. There is no reflex.
No,
There is no reflex.
not that I noticed.
About the nutrition, he fully breastfeed.
For the first 6 months, he is exclusively breastfeed, and then I started to wean him with like porridge, soft diet. And currently, he has been on adult diet, but he is no longer breastfeed now.
Or is he on a formula milk?
Yes, he's on formula milk.
Is he a picky eater?
No, he eats everything that I give him.
How about his weight? Is it according to the graph, according to the
Pardon me?
when you go to follow up, is it the weight and the measurement?
Oh,
according
yes.
to them?
Yes, the doctor that I see at the KK never mentions anything worrying. He said everything was fine.
Can you tell me about your family a bit?
So I am the mother. I am 25 years old. My husband is also 25 years old. We both had no non-medical illness. And I live with my second child. My first child is a boy as well, currently 5 years old. He is fine. We are all fine. We don't have any medical illness.
1 minute remaining.
Is there any history of cancer or any like hereditary disease in the family?
Not that I know of.
Can you tell me a bit about your person, about what do you work as?
I am a housewife. My husband is a teacher.
How about the income?
About 4,000 per month.
Where do you live?
In Taman Seri Indah. And also doctor, before he had the fitting or anything, I think I didn't notice whether he fall on his head or anything. I don't think so. I don't think. Before he had the fitting episode, I don't think he had like injury to the head or anything.
Okay. Recently did he pass out, or do you notice that he had have you noticed he had passing out recently?
No.
But there is no for me to clarify, if there is no diarrhea or any vomiting, right?
There is
Oh, there is
vomiting.
vomiting. But then there
2
is no
times.
diarrhea.
Yes.
How about the amount of the vomiting?
About maybe 1 cup each episode.
Did he able to cry like usual, or do you notice any other changes?
Not really. He only appeared lethargic.
Did you notice any blood or any mucus in the stool?
No.
Okay, thank you. We need to present now Wardati.
So my patient's mother. My patient is 1 year and 6 months old, Ali, which is a Malay boy with non-medical illness. That presented to the hospital due to fever and also sleeping for 1 week duration. Okay. So from what I gathered from the mother, it came that first there was fever, which is 36.9 degrees Celsius, which is low grade. Okay. There was fever, and which she noticed when she noticed there is one warm sensation patient, that he had done test funding and also had given him syrup paracetamol. However, the fever only resolved for a while before elevated again. And few hours followed by the episode of fever, there is episode of seizure. At the moment, he was sitting in the car, and the mother noticed that there is a sudden blank stare. That is, and he was unresponsive to her mother's call. And later, there was also upwelling of eyeball and also drooling of saliva. And then there is also generalized stiffness of the upper limbs and also the lower limbs. And after, and it only occurred for about 3 to 4 minutes, and later he had this weakness, and he looked a bit lethargic. Okay. So because of that, the mother bring him to the clinic, and he was given a supplementary paracetamol. And later, few hours later, there is second episode of eating, similar presentation like the first. There is also blank stare during a saliva and also generalized stiffness of the upper limb and also lower limb, about 3 minutes. But then there was no regain of consciousness, and there is another episode occurred with similar presentation. And the mother noticed there is cyanosis around the oral area. And the feeding occurred for about 15 minutes. And other than that, there is also a sort of infection, which is he had coughing and also runny nose for 1 day duration. Apart from that, there is no signs of ear infection or any GI infection, for example diarrhea. And there is also vomiting about twice, same onset with the fever, even no diarrhea or any other symptoms. He also had a poor intake and also lethargy for 1 day duration, even onset with the fever. Usually he had 3 times per day meal, but then it was reduced in quantity since the onset of the fever. Apart from that, there is no sort of infection from the urinary tract, or also no signs of any infection over the joint or any rest of the body. So the mother claimed that she also had the similar symptom, where she also had coughing and later contracted to her boy. And also he had history of going to the corridor area one day prior to the episode. Other than that, she didn't have any rapid breathing or any for the past medical history. This was the third hospitalization. He had 2 episodes of tonsillitis previously. However, no surgery has been done. And for the birth history, there was no significant history. He was born at 58 weeks term and with normal weight 2.1 kilogram and so the normal delivery. So for the development is up to his age, and for the vaccination is according to the schedule, especially for the HIV and especially for the HIV, the claim that the boy did take the vaccine. There was no injection of any drugs or any toxin. For the family history, there was no history of genetic disorder in the family or no malignancy. The mother is well, and the mother and the father is well. And this boy is second son of the family. He had the brother 5 years old. However, there was no significant medical history. So for the personal history, he was a housewife, and his husband is a teacher. They get about 4,000 per month. Living in that's all that I able to gather. Let's see. So for my provisional diagnosis, I believe it's status epilepticus secondary to I think it's status epilepticus secondary to UITI, meaning upper respiratory tract infection. Because of the seizure was coincide with the fever. That is the source of infection, I believe, is upper respiratory tract, because he had cough and also runny nose, contracted from his mother. And also why I say status epilepticus is because he had this multiple episodes of seizure within 15 minutes, and there is no regain of consciousness in between. Okay, so that is my provisional diagnosis. Second, for me is because there is fever, so I believe it's effective in cause, so I would like to put meningitis as my second diagnosis. However, there's only fever and also seizure. There was no other symptoms, for example, like weakness or that can suggest meningitis. But then, and the third one is epilepsy. However, for epilepsy, the patient had seizure, but then it was preceded by fever. And from the family history or the birth history, there is no significant history. For example, like probably hypoxic state during the birth, or there is no genetic disorder in the family that may suggest that this patient had underlying neurodevelopmental disorder that may precipitate the epilepsy. Other than that, the seizure could be because of metabolic cause. For example, hyponatremia, as this patient had vomiting for twice per day. But then that is the only symptom. There is no other, for example, like diarrhea that can precipitate more the hyponatremia. And hypoglycemia can also be one of the cause for seizure. However, it's quite uncommon in infants. Okay. It could be also because of cardiac cause. But then there is no underlying heart disease, or there was no symptoms of pain or easily fainting that could suggest that this is cardiac in origin. So that is for my decision.
Any other diagnosis?
It can be due to trauma, but then trauma has already been ruled out. It could be also because of case of inflammation, for example, like cerebral tumor. But then there is no history suggestive of case of inflammation, for example, like projectile vomiting or headache. But then you can really assess headache in anything. There's also no history of malignancy in the family.
Can be non-accidental injury.
For example, abuse.
Yes.
But then I can assess on that.
Okay, even some like shaking baby syndrome, sometimes it can cause bleeding, and the intracerebral hemorrhage can cause some fever also. So, okay, how can you differentiate between meningitis and encephalitis?
Actually, the symptom is quite similar, but then I believe for encephalitis, usually there's also association with afiqah behavior. And
can you increase your voice, please, slightly? Increase your voice slightly.
Okay. I believe meningitis and encephalitis is quite similar, but then encephalitis is also association with alteration in behavior. And but more or less it's quite the same.
Who can answer?
With regards to the
Leslie?
etiology.
Yes.
With regards to the etiology, meningitis is more commonly towards the bacterial meningitis. But for encephalitis, usually it's viral cause, for example, like enterovirus or
No,
other.
I'm asking about clinical presentation.
Encephalitis don't have any nuchal rigidity, like stiffness, in encephalitis. It's such nuchal rigidity is a meningism, which indicates meningitis instead of encephalitis. And then in encephalitis, from internal medicine mentioned that one of the lecturers mentioned that it's will have seizure as compared to meningitis, can or cannot have seizure.
Who can answer?
Is it
We are 20 plus now. Yes, yes, please.
is it like the nature of the fever, such as like if it's encephalitis, which is viral cause, so it's usually is more okay. So I'm not sure.
No. I'm asking clinically. She must ask in the history about some important points. It will guide here. Is it meningitis or encephalitis? Of course, meningitis. We know Zakirnex, Brodzinski, and other. Okay, stiffness. But for encephalitis, you must ask sharply about, even if the patient doesn't mention, because sometimes the patient cannot understand the importance of many symptoms. Simple thing. What about photophobia?
Oh,
Photophobia. If the mother informed you that the patient cannot open his eye in light, he has a photophobia, so we'll suspect meningitis or encephalitis.
Okay.
If some behavioral changes, it will go with encephalitis.
Encephalitis.
So in any case, you suspect meningitis or CNS infection, you must ask about that, because sometimes you have meningoencephalitis. They are together, not one. It is one pathology, but which part is affected? Is it only the meninges, or it came to the brain tissue itself? Okay, so it is very important if you suspect any meningitis to rule out encephalitis and ask about the detail. Again, your main diagnosis is simple febrile fit, secondary to
upper respiratory tract infection.
can be secondary to COVID.
Okay.
Why you are not getting the lesson? Any patient has fever, have ILI, influenza-like infection. Any patient has these symptoms, you must be very cautious nowadays. It is the same before. If you have one patient with fever and you didn't say, I ruled out dengue by the history that the patient has no insect bites, he is not living in dengue-prone area, he doesn't got some symptoms like that, blah, 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 and I can find the tonsillitis, you may be not achieving good. Can be, still can be, yes? So please, any communicable disease must be put in our fields. We are not allowed to underestimate it. The other things, what is the difference between simple or complex febrile seizure?
Okay, so the duration is less than 15 minutes, and usually it is generalized seizure, and usually there is no recurrent episode. There's only one episode of seizure during that time. But for complex, it's more than 15 minutes, usually focal, and there is multiple episodes of seizure during the febrile episode.
So beside examining the CNS for any signs of meningeal irritation, what other system do you need to examine?
Cardiovascular system.
Sorry?
Cardiovascular system.
Why?
Because seizure can also be precipitated by cardiac cause. For example, like syncope. And also in seizure, there can be also cyanosis. So cardiovascular disorder also can present it with cyanosis.
What other system, important system?
Abdominal examination, because could be there is a gastroenteritis or any gastroenteritis that can cause fever and later on cause seizure. Precipitate the seizure.
Okay. One more system? What about the
respiratory?
Skin? No. What about skin? I will just speak about dengue and the cutaneous manifestation. Is it important to examine skin in any even neurological exam or not?
No, it's important because some syndrome can lead to seizure. For example, like Weber syndrome or neurofibromatosis.
What is the name of this group of diseases?
Epilepsy syndrome.
Neurocutaneous disorder.
Neurocutaneous syndrome. It is about 9 or more. Your colleague mentioned now the most common one, which is neurofibromatosis or Weber or other. Remember that the brain and the skin, both of them are coming from ectoderm. So that is why we have this combination, neurocutaneous syndrome. So please don't underestimate the importance of examination of the skin. Also, in this situation, if I suspect the most common cause of meningitis is the meningococcal, what I can find in the skin, if it is meningococcal, is very important also.
Purpuric rash is
Yes,
usually
this is very
regulated.
important. Very, very, very important. If you find purpuric rash, and you must know how to differentiate purpuric and other viral rash, and you found someone who has convulsion, who has a fever, he has even meningitis or encephalitis, and you found this rash, don't wait. You need to take decision to give him the available antibiotic, either penicillin or ceftriaxone, and send him directly to the hospital. This is the most important. Of course, our incidence for febrile convulsion is high. And it is good to know the most common cause in your area, but don't forget the uncommon. Because inside all this, sometimes we can miss an important case. The last question for you, what about the A, B, C, D, E resuscitation for case of CNS problem?
And so for the resuscitation, especially for the airway, we need to make sure it's open, because in patient that has loss of consciousness, or they can also be respiratory depression, and also to supplement oxygen if there is any episode of hypoxia. And if the patient is, if the seizure is due to infective cause, it can also lead to septic shock. So we need to monitor the blood pressure and the vital signs. If there is any tachycardia or tachypnea or any hypertension, and we need to resuscitate the patient accordingly.
So this is AB.
Breathing and circulation.
Okay, C is
circulation. In circulation, because if the patient has any hypovolemia, then we need to resuscitate the patient with resuscitation.
Okay. D. Who knows about D? It is 3D, not 1D. 3-dimension. The most important for case of convulsion, the most important D is the
Disability.
Sorry?
Dextrose.
Yes.
And don't forget about sugar.
Yes. Very important. Do you know that if child got hypoglycemia, and even you are upgrading your anticonvulsant without correcting the blood glucose, the result is not good. Okay, so number 1, dextrose. Number 2, disclosure. You need to check the skin, which I just speak to you. You must disclose, looking for any rash, for any neurocutaneous, for any symptoms of child abuse, like that. Okay, so the first D is dextrose, the second one is disclosure, and the third one, is there any deficit, neurological deficit? It's very important. Sometimes the criteria to consider simple or complex or typical or atypical is the post-concussion, post-convulsion period. If he got like Todd's paralysis, if he's got like any hemiparesis, any problem which are extended more than 2 hours like that, you must consider this. So don't forget, please, It is very important in resuscitating in any patient with CNS or convulsion problem. Okay. Can we go through the OSCE, please?
Yes, Prof. I'll share the slide.
Thanks, Zaki.
Can you see my slide? All the other students? Hello?
Yes, we can see.
Yes, yes.
Okay. Okay. So this slide is prepared by Akila. So Akila, you want to conduct the session?
Okay, so here's a picture of PP. It could probably be not so prominent, but I want you to observe around here, around the. Can Aqlan shows the cursor on the
Just
around
a
the
second.
front area?
Can you see the cursor?
Yep. There. What is this finding? That we could find in patient who suspected meningitis.
Bulging fontanelle.
Yes, it's a bulging fontanelle. But I'm sorry, this is the best picture of bulging fontanelle that I could find over the internet. Probably it's not so prominent.
Yeah, it is. Thank you. It is very also good one. Any infant or toddler below 18 months or even for the second year, you must comment about the anterior fontanelle. Okay, is it bulging or depressed? Is it closed or not closed? Is it wide or not? It is very important. Even you are commenting for dehydration, you must start from up down. So you will start by the anterior fontanelle, then coming to the eye, then coming to the mouth, then coming to the hand for capillary fill time and skin turgor and all that, please. Okay, don't forget that anterior fontanelle give you a lot of information. Sometimes if it is pulsatile, it is very important. Maybe the child has AV malformation. Sometimes even you can hear murmur if there is AV malformation. Okay.
Prof, I have a question.
Yes.
In meningitis, the bulging fontanelle is a manifestation of increased ICP. May I ask, in meningitis, do we really need to check for the cranial nerve number 6 for the false localizing sign as part of the increased ICP sign?
Yes. Yes. Ideally, yes. But sometimes the presentation in infant which is below 1 year is a bit different because, like Babinski, it is normal to be upgoing at that age. So sometimes you can rely on hyperreflexia, it will guide you. Even Kernig's and Brzezinski sometimes is not so beneficial at that age. So anterior fontanelle and the other neurological examination is very, very important. Okay.
Okay. This is the finding in this patient, correlate with the history. Anybody would like to answer?
Injected pharynx.
Yeah, it is just a sign of injected pharynx. This patient also has cough, so it slightly correlates. He could probably have some sort of pharyngeal infection. Move on to the next.
So nowadays, please, you are not allowed to examine the mouth and the respiratory system without wearing your mask, and it is advisable also to use level 2 PPE. So if the patient has COVID, you are not getting the infection. You must have a goggle and a face shield so the microorganism will not come directly to you. Okay.
So this is actually a video. Can Aqlan please play the video? This is sign.
Actually,
Can I?
the video cannot be played, but the other video can. This video cannot.
Okay. It's okay. Can play the other video.
This is kening kan?
Yeah. This is actually the video shows that when you lift up the right leg, then the left leg of the patient is actually being raised as well after we extend the knee of the right knee. But
Sorry,
unfortunately, it
your
can't be
voice
played.
is not clear. Can you again, please?
So the previous video is actually the manifestation of chronic sign, whereby the doctor flex the hip and also the knee first at 90 degree, and then with extension of the right knee, this baby or this patient actually had lifting of the left leg.
Okay. Yeah, that's good. Yes.
Later I will share the chronic sign video with you guys. So this is the second video. Can anyone answer what is this sign and explain how it is being performed? Yes, it's Brzezinski sign. So how it is performed?
When we flex the neck, so you can see there is a flexion of the hip of the baby too because of stiff.
Yes, it is Brzezinski sign, and it also occurs due to the irritation of the meninges.
So please remember that it is shameful in the exam if you are not able to do this meningeal irritation signs. Okay, thank you. The other slide.
So this is the skin manifestation that could occur in patient with meningitis that we should look for. Anybody would like to describe and also give a spot diagnosis of this rash?
So this is rash because of the meningococcal infection. As you can see, there is a purpurate rash scattered along the lower limbs. And the second picture, as you can see, it is irregular in shape, and at the center there is a necrotic area. So this is suggestive of meningococcal infection.
Yes, this is a skin manifestation of patient with meningococcal meningitis or meningococcemia. Next slide, Aqlan.
No, please.
Okay.
Come back. Is it normal for any patient to have this connection inside the mouth?
There is.
I told you before, you will not be a good physician until you are a good observer. You must say this child has intubated and connected to mechanical ventilation with cardiac monitoring and has that rash, because it gives us a clue that the patient is in severe situation. He is intubated now, okay? Because it is not normal. If you found anything extra normal, I don't understand. You must be able to comment about that. Am I clear?
Yes, bro.
Yes, sir.
And also the other, the rashes in the face and the chest, it looks like needs more details. Is it berberic? Is it gangrenous? Is it vesicular? It's very important. If I see that face without seeing the leg, I may consider, is it varicella zoster? Is it herpes simplex? Do you know that? Herpes simplex encephalitis is life-threatening one. If it came to the brain, it is life-threatening one. And the mortality and the morbidity is very high, especially in young children. And you must take care, even if the patient have some atopic dermatitis and he got herpes infection over that, it is very, very, very dangerous and you must take it seriously, okay? So can be meningoencephalitis, should we consider herpetic or not, should we consider chicken pox, all this must be kept in mind, okay? Next slide, please.
Prof, may I ask, do patients with meningitis regularly presents with this meningococcal rash, Prof?
Yes. Yes, if the causative organism is meningococcal, you will find this type of rash.
Thank you, Prof.
This is just a picture to show that the rash in meningococcal meningitis is actually a type of non-blanching purpura.
Yeah, but what is the ideal glass you are using? The microscopic glass. Not drinking glass, okay?
Yeah, I'm sorry that I couldn't
Okay.
find the picture.
No, yeah, no problem. I'm just if you find you will, ideally, if in any clinic must be like one microscopic slide just to press and they can see behind, because sometimes the gap between your pressure and the reading your hand can make you uncertain. Okay, very good to define any barbaric rash. It is dangerous. It is serious. Don't go to it simply, please. Okay. Good. Next slide. Yes, you picked the point now. So what is this? Who will comment?
Is it cafe de aule in neurofibromatosis patient?
Why you diagnose neurofibromatosis?
Because of the cafe de aule spot.
Diagnosing neurofibromatosis. Any patient with café au lait will be diagnosed as neurofibromatosis?
Not necessarily.
They need to fulfill the criteria, Prof. 2 or more out of 7 or 9. 2 or more.
At least 6.
Yes.
At least 6 spots.
At least 6.
There is criteria for the number. There is criteria for the size. Even a small one cannot be counted. Must be different size with age. Is it for a young age? Is different than the eldest child. So it is very important. Is there any neurofibromas or not? What about if you go and get a look for the axilla, what you are searching for? So there is criteria for the disease. Don't be hurried to say it is neurofibromatosis. At least you can say, my job is to rule out neurofibromatosis. Even medicine has, you must be a bit diplomatic. Okay? Am I clear?
Yes.
Just revise the criteria for diagnosing neurofibromatosis, please. It is very important.
Okay, Prof.
Okay, next slide.
Akila?
No, this is not an OSCE question. This is just a revision for neurocutaneous stigmata, which is related to syndrome, certain syndrome. That's all for the OSCE question that I prepared.
Yeah, thank you. It is a good slide. At least we know some more about the neurocutaneous syndrome. Now we have remaining 2 minutes. I will leave it for you if you need to ask any question.
So for the etiology of meningitis, for the bacterial meningitis, for example, the meningococcal and also the pneumococcal meningitis, can we differentiate through clinical, or instead of yes, we can do the lab investigation, the culture and sensitivity, but then clinically can we differentiate the etiology of the meningitis?
Yeah, our normal procedure for any patient is history, which will give about 70% of the story. Then clinical examination, which can give 20 to 25. Then some investigation, which will confirm at the end. If you go through the history and find this child doesn't got any vaccination, okay, and has a chronic cough. So what is the suspicious now?
Could be HIV, hemophilus. Could be hemophilus influenza.
No, chronic cough.
TB meningitis.
So TB. Okay, I must consider TB. So I will come back to the history. Is there any night sweat? Is there any loss of weight? Is there anyone of the member of the family has TB? Is there anyone of the family like that? So the history must be working. We are like a circle. Sometimes I need to repeat to confirm. If I got a thread, I must follow it until I can reach the diagnosis. Okay? So history, clinical examination, but even at the end, you need some investigation to consider. But it is very important, as you know, that if I consider pneumococcal meningitis, they are advising to give steroids even before the antibiotic. You are going to give dexamethasone and then give the ceftriaxone or whatever you are using, penicillin or like that, because it will protect the hearing. Okay? So if you have suspicious, you are going for that.
Thank you.
Prof, I have two questions.
Yes.
First and foremost, with regards to the antibiotic in meningitis, because in internal medicine, before we get the lumbar puncture result, we just bombard all the either viral or bacterial or fungal. Do we do the same in pediatric, Prof?
Again,
Before we get the lumbar culture, CSF analysis, before we get the results, so we don't know yet the etiology. Do we need to bombard like all of the viral, bacterial, and fungal before we get the CSF results?
No, for us as a pediatric, fungal infection needs some rare situation, so it needs glue, but usually we are going to consider bacteria, but if there is any clue for viral, like the one we see before, like herpes simplex, if there is varicella, yes, we are going to add antiviral, acyclovir, and if we suspect pneumococcal, we are going to give dexamethasone.
Thank you, bro.
Of course, the most important point, I think I speak with one group of you about how to do lumbar puncture. and how many bottles do we need? Usually we are collecting for the CSF 4 bottles, okay, as essential one. But if we suspect anyone, sometimes we are collecting 2, 3, 4 more bottles. If we suspect viral, we need to send for viral. If we suspect TB, we can send for TB, like that, okay? The other question, Zaki?
My other questions will be, when we have a patient presented with seizure, when do we need to do the EEG as part of our workup, Prof?
Sorry, when?
When a patient presented with seizure,
Yeah.
when do we need to do the EEG, Prof? The electroencephalogram.
So I will ask you one question. What is the definition of epilepsy?
2 or more unprovoked seizure, Prof.
Okay, it is 2 or more. Usually in the first spike of convulsion, we are not starting by the EEG unless there is clue that can be epilepsy by family history or by other things, or some impact for that, like herpes simplex encephalitis can be diagnosed by the EEG. It will be left temporal lobe affection. It will appear in the EEG. But EEG is a gold standard for diagnosing epilepsy. And even epilepsy is a clinical diagnosis, because some patient of epilepsy may be 5 or 10% still got normal EEG. And some normal people has abnormal EEG. I know that it is a small number, but it happens. So in any investigation, to be more professional, you must have rationale. And during the exam, and I used it to tell you, our life as a medical practitioner, every case is an exam for you. And it is not good to pass in front of people and fail between you and yourself. If you ask any investigation, because I found many colleagues now doing something known as blanket investigation. What is the problem? It can be dengue and leptospirosis and other. So please, Bismillah ar-Rahman ar-Rahim, full blood count, CRP, CSF, urine, dengue, leptospirosis, blah, 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 blah. Go and do this investigation and come back to me. How many wrong thing done now?
All but one.
Yeah, he is doing a lot of investigation and wasting a resource of the country, or wasting a resource of the person if he is going for private. And you are losing your clinical sense. You are not able to differentiate between the things, so you are. And the most bad thing at the end, it may be ended by you are writing also treatment for 2 cases. It is very bad. Don't, please, let your clinical professional be weak with time. Any test you are going to do, you must have rationale. And you said, sorry, I'm going to do UFME searching for UTI or hematuria or RBC casts or albuminuria. You must say what you are searching for. I'm going to do abdominal ultrasound. I would like to see the QB, or I would like to check the gallbladder, or I'm going to check other organ, appendicitis. So every time you are asking for investigation, you must give the rationale for requesting it and what you are searching for. At the time, you are a professional one. Okay, don't do blanket investigation, please. Don't do blanket investigation. That's why, even I ask your colleague in the 3rd year, can you please make a simple article about the how to read full blood count. Still, some of us are lagging for that. It is full blood count, which is the most common one. And I mean by CBC here, complete blood count, just to include for your level now the blood film, which is very important. If I ask for blood film, what I am asking? It is very simple test, but you can rule out leukemia, you can rule out thalassemia, you can rule out many chronic hemolytic anemias. So also the second point which I ask you to do, if you are able to do a complete blood count, how to read and how can make benefit of every one of the criteria of the RBC and every one of the differential white count, when I will find neutrophil high or low, when I can find the lymphocyte, when I can find eosinophils, monocytes. It is very important. This is everyday practice, and sometimes we are not concentrating on it. So if someone also will do the COVID clinical presentation and examination and the precaution during the investigation, during the examination, and one can do for the complete blood count, please. Okay? You can even put it in the group. The last request from you, because I didn't make attendance sheet for you, I need just to write the dates and who is the presenter in every meeting. This one is doing a role player, and this one is doing presenting the case, and the third one who is doing the OSCE. Okay, please try to make it retrograde and send it to me for both group. I think you are 2 groups today. My group 3 and the group 1.
Yes, Doctor.
Yes, and if we inform also the other group for that, so it looks, inshallah, soon you will come to the hospital, so we can do archive all that, and I can put your marks inside, inshallah, the logbook. Okay.
Okay, Prof.
Okay, thank you. See you, inshallah, soon.
Prof.
Thank you, Prof.
You are welcome. You are welcome. Assalamu alaikum warahmatullah.
Waalaikumsalam warahmatullah.
Dah.
Thank you, itu.
Boleh.